Mike Gibson, Karim Al-Azizi, and we're talking about how you can use CT to help guide your PCI procedures. So, Karim, talk to us about your practice and how you're using CT to help guide your PCI procedures.
Yeah, thank you, Mike. I think CT has evolved significantly. We started early on with more of a rule in, rule out, calcium scores for screening and prevention, and more now to more of a prescriptive form in taking that tool and that test to the cath lab. Not only as a gatekeeper, but also as a tool that really will guide the intervention from simple lesions to complex bifurcations to even CTO tools and planning CTO PCI in a lot of those patients. The way you use it is basically just like an app on your phone. You can use the app to its extensive extent, essentially, of knowing it, understanding, and how to use all the data that comes out of it, or as minimal as green light, red light, or intervene or not to intervene. What we have evolved, our team, specifically at our site, and working very closely with our imagers, is to understand plaque, understand involvement, understand how to actually plan this, just like a structural heart procedure. You don't have a TAVR nowadays going in without a CT. So a lot of times for us as well in complex interventions and with the wide adoption of CT as a first tool and a first test for those patients is to use that to guide our revascularization plan.
So, tell me, what types of things are you looking at on the CT? How does it guide your procedure? Do you have the CT up there right in the lab while you're doing the procedure? Walk us through how you're actually using it.
So, for example, if a patient was referred, for a PCI or a complex CTO PCI, for example, in the lab, and had a prior coronary CT, a few things are very helpful from that. Number one, looking for tortuosity just simply in the subclavian if you're going to do a radial PCI. Number two, understanding the size of the guide, just measuring from the ascending towards the left main if you're doing, for example, a complex left-sided intervention that will help you guide and understand the size of the guiding catheter that you need to use. Then going further into the coronary arteries and understanding the lesion, the complexity of it from calcification. Really, it's the bottom line is calcium, right? Where the calcium is the enemy. You're trying to understand what is the best way to treat and modify the lesion to improve the vessel compliance to actually get the best stent expansion. And obviously, bifurcation lesions. Why is that important? Because, branches do matter. And depending on the size of the branch, you may elect to, protect the branch, to dive into a complex bifurcation stenting or intervention. Really dependent on the amount of myocardium that is supplied by that, which is all information given to you based on the CT. The way we use it is a lot of it is pre-planning, and you look at it beforehand. You understand what is being involved, what are the fluoro angles that can be mimicked from the CT that can be translated so that you don't have to waste time taking 4 and 6 angiographic pictures in order to really get that ideal angiographic angle. And similarly, you can transmit that image just simply from a web-based platform on your computer in the cath lab that is slave to your screen on your cath lab where you're operating to be able to actually see what you're doing. Now, there's multiple, obviously, softwares, and a lot of these softwares are working on things that will have a live, basically, fluoro co-registration in order to allow real-time feedback on where exactly you're putting your devices. But I want to
Yeah,
really highlight, yeah, go ahead.
I was just going to ask about geographic miss and also stent length, knowing the extent of the plaque, the length of the plaque, perhaps that might help. How good is the CT and also helping guide stent diameter in terms of your choices there?
CT has not yet completely predicted stent diameter, although there is a lot of data coming out. But in our day-to-day experience, we can tell that, especially in vessels that are underfilled due to critical stenosis, they may sometimes be undercalled. We've seen obviously examples of negatively remodeled vessels, especially in CTO-PCI beyond the occlusion segment. And so that I would approach with caution. And that's where actually intravascular imaging still plays a major role in the intra and post intervention assessment in order to make sure that you don't have misses or you don't have dissections that need to be addressed or covered.
Yeah, so, do you envision a day where perhaps CT would minimize the use of some of the intravascular imaging? It could get to be better in terms of resolution, sizing, morphology of plaque, identification of calcium, things like that.
I certainly see this coming, Mike, because, in a lab where we do a lot of intravascular imaging in our PCIs, almost every patient that I personally do require intravascular imaging unless I can't pass an imaging catheter. I will tell you that the bottom line is the role of predetermining what size of balloon or what size of plaque modifier, or if I need to use atherectomy right off the bat by intravascular imaging is already taken out of the equation. And we're already moving forward with that plan without having to pass an intravascular imaging catheter to predetermine if we needed to do that if you had CT, but it still is required intraprocedurally to understand if your plaque was modified and if your stent is well opposed. I do believe that there is a day that will come with more data, and there's multiple trials that we're part of that will help inform us whether an intravascular imaging first or a CT based only guidance is good enough in terms of clinical outcomes.
Do you ever find some lesions that the wall and the biology is such that maybe they would benefit from intervention that wouldn't be defined on traditional angiography?
The evolvement of CT, and this is actually understanding plaque. And as an interventional cardiologist, it's very important to understand the complexity of the plaque. It's not just the calcium and we intervening, but actually understanding the biology and understanding the lipid-rich plaque, the vulnerable plaque, the plaque that is considered high risk in helping inform patients and actually convincing patients to taking some of these medications. And I do think that as we evolve more and more in the science of intervening on vulnerable plaque or high risk plaque, I do think that CT guidance and understanding that from the get-go will help inform these decisions.
Right. Well, I look forward to a day where we integrate this kind of imaging into risk prediction. What we've done so far is demographics. We've used the traditional plumber's model of how tight the arteries are, how many stenoses there are. But I look forward to a day where we characterize the biology of plaque and the extent of plaque in the wall, not lumen, and make a lot better decision making in terms of long-term prognosis, maybe duration adapt or lipid lowering, things like that. GLP-1, make your arteries skinny again. So exciting times, exciting times. Great to hear from you about how you're actually using this in practice. Sounds like you're really using it very efficiently. Thanks for joining us today.